Bacterial meningitis, acute inflammation of the meninges. Look at this picture shows that brain meninges and CT scan findings. Look at this MRI findings. Look at this. A detail going on. Introduction. Bacterial meningitis is a serious, life threatening infection of the meninges. The protective membranes covering the brain and the spinal cord. It requires immediate medical attention due to its rapid onset and potential to cause permanent neurological damage or death. Despite advances in medicine, bacterial meningitis remains a global health challenge, particularly in infants, elderly people, and immunocompromised individuals. Definition. Bacterial meningitis is acute inflammation of the meninges caused by bacterial invasion, typically involving Streptococcus pneumonia, Neisseria meningitidis, or Haemophilus influenza type B. The infection can spread to the cerebrospinal fluid (CSF), triggering an immune response that causes swelling of brain tissues. Etymology. The term meningitis comes from the Greek words meninx meaning membrane and it is meaning inflammation, referring to inflammation of the membranes covering the brain and spinal cord. The word bacterial is derived from the Greek bacterion, meaning small stuff or rod, describing the shape of many bacteria. Epidemiology. Bacterial meningitis affect people worldwide within the highest incidence in infants, young children and individuals in low income regions, particularly the meningitis belt of sub-Sahara Africa. Despite vaccination efforts, outbreaks still occur and the global mortality rate remains significant, ranging from 10% to 30% depends on the causative organism and access to healthcare. Type. Bacterial meningitis can be categorized based on causative organism or the age group affected. By causative agent 1. Streptococcus pneumonia, pneumococcal meningitis. 2. Neisseria meningitidis, meningococcal meningitis. 3. Haemophilus influenza type B (HIB). 4. Listeria monocytogenes, listerial meningitis. 5. Group B Streptococcus, mainly in newborns. 6. Escherichia coli, also come in neonates. By age groups, neonatal meningitis, childhood meningitis, adult meningitis. Nosocomial meningitis, hospital acquired. Causes: bacterial meningitis is caused by bacterial pathogens that gain access to the central nervous system. Common causes include: 1. Bloodstream infection. 2. Sinus or ear infections. 3. Skull fracture or trauma. 4. Post-surgical infections. 5. Congenital immune deficiencies. 6. Maternal transmission during childbirth. Risk factors: 1. Age. Infant and older adults are at high risk. 2. Living in close quarters, dormitories, military camps. 3. Weakened immune system, HIV/AIDS, cancer, diabetes. 4. Head trauma or neurosurgery. 5. Unvaccinated status. 6. Chronic ear or sinus infections. 7. Splenectomy, spleen removal. Complications: 1. Seizures. 2. Hearing loss. 3. Hydrocephalus. 4. Brain damage. 5. Cognitive impairment. 6. Shock and organ failure. 7. Death if untreated or delayed treatment. Pathophysiology. Pathophysiology of bacterial meningitis, step by step process. 1. Colonization of mucosal surfaces, bacteria. Example: Streptococcus pneumoniae, Neisseria meningitidis. First colonize the nasopharyngeal or respiratory mucosa. 2. Inversion of the bloodstream. The pathogens penetrate mucosal barriers and enter the bloodstream, causing bacteremia. 3. Crossing the blood brain barrier, BBB. The bacteria evade immune defenses and cross the BBB via transcellular penetration, paracellular movement, Trojan horse mechanism for entry into the cerebrospinal fluid CSF. Once across the BBB, bacteria enter the subarachnoid space and proliferate rapidly due to limited immune surveillance in the CSF. 5. Activation of the immune response. Bacterial components like lipopolysaccharides or teichoic acids trigger a host inflammatory response, attracting white blood cells and releasing cytokines. Example TNF, alpha, IL-1, IL-6. 6. Increased permeability of the blood-brain barrier. The inflammation causes BBB disruption, leading to vasogenic cerebral edema. 7. Increased intracranial pressure ICP, edema, impaired CSF flow, and increased vascular permeability rise ICP, which reduces cerebral perfusion and oxygen supply. 8. Neurological damage and brain dysfunction. Elevated ICP, direct bacterial toxins and inflammatory mediators contribute to neuronal injury, brain swelling, and potential seizures, coma, or death. Signs and symptoms. 1. In adults and old children, high fever, severe headache, neck stiffness, photophobia, altered mental status, seizures, nausea or vomiting, skin rash, sensitivity to light. 2. In infants, bulging, spontaneal, poor feeding, irritability, lethargy, seizures, high pitched crying. Diagnosis. 1. Physical examination. 2. Lumbar puncture, spinal tap, CSF analysis for WBC, protein, glucose, gram stain, and culture. 3. Blood cultures. 4. CT scan or MRI to rule out brain abscess or increased ICP. 5. Polymerase chain reaction PCR for specific pathogens. 6. Serum procalcitation may support bacterial over viral cause. Nursing diagnosis. 1. Risk for infection transmission related to contagious nature of disease. 2. Acute pain related to headache and meningeal irritation. 3. Altered level of consciousness related to cerebral inflammation. 4. Risk for seizures related to cortical irritation. 5. Impaired sensory perception related to increased ICP or inflammation. Medical management. 1. Empirical IV antibiotics immediately. Example, ceftriaxone plus vancomycin. 2. Tailor antibiotics once pathogen is identified. 3. Dexamethasone to reduce inflammation, especially in pneumococcal meningitis. 4. Antibiotics. 5. IV fluids for hydration and electrolyte balance. 6. Anticonvulsants if seizures occur. 7. Oxygen therapy if hypoxic. Nursing management. 1. Monitor vital signs and neurological status frequently. 2. Maintain a quick, dark environment to prevent overstimulation. 3. Monitor and manage fluid intake output. 4. Ensure infection control measures. Droplet precautions. 5. Elevate head of bed to 30° to reduce ICP. 6. Administer medication on time and monitor for side effects. 7. Educate family about disease, transmission and treatment. Treatment options. 1. Empiric antibiotic therapy before pathogen identification. 2. Targeted antibiotic therapy based on culture results. 3. Supportive care, fluid, electrolyte, antibiotics. 4. Steroids, dexamethasone to reduce inflammation. 5. Surgical drainage if abscess or hydrocephalus occurs. 6. Rehabilitation therapy for neurological defects. Psychosocial medicine. 1. Emotional support. Reassure the patient and family, reduce anxiety and fear. 2. Education. Explain procedures, medications, prognosis, and preventive measures. 3. Family involvement. Encourage family presence to reduce patient's isolation. 4. Support groups. Refer to post recovery support communities. 5. Mental health counseling for patients with PTSD, depression, or cognitive impact. Post illness. Prevention. 1. Vaccination, HIV vaccine, pneumococcal conjunctive vaccine, PCV13, meningococcal vaccines. 2. Prompt treatment of ear, sinus, and respiratory infections. 3. Antibiotic prophylaxis for close contact. 4. Proper hand hygiene. 5. Avoiding overcrowded places during outbreaks. In conclusion, bacterial meningitis is a medical emergency with potentially devastating consequences. However, with early diagnosis, aggressive treatment, and preventive measures like vaccination, the prognosis can be significantly improved. Nurses play a vital role in monitoring, educating, and supporting patients and families. During this critical illness, multidisciplinary approaches ensure holistic recovery and reduce long term complications. Thank you. Have a nice day.